Good afternoon, dear students and doctors. We welcome you all today to the student-led Alfaisal Mini-Med School Series. I would like to introduce you to our valued guest for today, Dr. Rania Alobari, a graduate of pharmaceutical science and a certified professional in healthcare quality. Currently a performance improvement specialist at KFSH. She will be discussing the topic of patient safety and its significance in the medical field. Now please give a warm welcome to Dr. Rania Alobari.
Thank you, Alfaisal, for this warm welcoming, and I'm honored today to be with you to have this topic. It's very, very hot topic, actually, and as you can see from the outline, each subject I can talk for a day about it. However, I try to summarize as much as possible. I consider today's presentation will be like an eye-opener for all of you as a medical student, because really we depend on you for the future and for the safety of our patients. My presentation name is Why Patient Safety. So today we will understand together why really it's very important to consider it while you are practicing medicine. So, first of all, really, I'd like to have some facts that will help you to know that, to understand and to realize the importance of patient safety. I need you to think about the patient that are coming to the hospital or to your clinic as a beloved person for someone. If I will ask you now to raise your mobile and let's see what's your screensaver picture that you have. It could be your mother, it could be your father, it could be your daughter, your sister, your inspiring person that you love and you like to see always. So always you need to consider that those patients are a picture person for someone. And their expectation is, as in this sequence, don't harm me, heal me, be nice with me, in this order. So this is the expectation that they have. Of course, let's start with this Quran recite that it says, وَمَنْ أَحْيَاهَا فَكَأَنَّمَا أَحْيَا النَّاسَ جَمِيعًا, in English. And if anyone saved a life, it would be as if he saved the life of the whole people. Some statistics that are really important to keep in mind and to remember, that medical error as PMG that they have published in 2016, that they are the third leading cause of death in USA. This is the statistic of USA that's been published in 2016. Sure, today it's maybe more. What about our statistics? Also, National Patient Safety Foundation in 2015, they have published that 10% of admitted patients are affected by medical error. So 10%, it's quite a huge number. And when we say medical error, it could be of a different type. It could be related to medication. It could be related to treatment, medication management, wrong diagnosis, name it. Again, another fact that you need to keep in mind, that preventable harm causes healthcare provider burnout and serious psychological trauma, and we call those the second victim. Many stories that we have heard about a healthcare practitioner who quit his job or her job because of a medical error, serious medical error like death. Imagine how you can live if there is a person or a patient, no matter what his or her age, get affected with a serious injury or death. I think really it will be very traumatizing, and sometimes and in most of the time it lead to be the second victim and quitting your job. Let's define the patient safety. As per the World Health Organization, they said the definition of patient safety is the reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. Why we are saying here acceptable minimum? What do you think?
You can never
100%. We are a human. Still, no matter how many measures we will put in place, we will do some errors. However, we need to have measures in place to help us to make it to the minimum. Another definition by the National Patient Safety Foundation, they said it's the avoidance, prevention, and amelioration of adverse outcomes or injuries stemming from the process of care. Why we are saying stemming from the process? Why we are not saying from human? What do you think? Are you coming to your clinic or to your hospital today with the decision, I will kill 2 patients today? Of course not, right? It will be crime. So this is why we are saying that most of the errors, it's stemming from processes, from system failure. It's not a human failure. You are not intentionally doing those errors. Another definition by Institute for Healthcare Improvement, freedom from accidental injury. So what is exactly patient safety? Now, some pioneers in the field of patient safety, they met and they had their society, they reviewed reports, articles, case studies, and they decided that it's a discipline that applies safety science methods towards the goal of achieving a trustworthy system of healthcare delivery, an attribute that minimizes the incident and impact on maximize recovery from adverse event. So again, you need to have something in place that help you to recover. So it's not the end of the life. When something happened, you need to stand up. You need to be resilient. You look at what happened, fix it, learn from it, be transparent, and continue. Of course, we need to learn from others. Other industry like railways, aviation, nuclear planets, because they are pioneers in safety. Of course, maybe if you have read about safety and high reliability organization, you will find those industries are really the pioneers. They led to the development of framework of safer workplace. So again, it's us as an employee in a healthcare institution that really we need to feel that we are safe doing our work at safe place and in a safe manner. Accidents are usually the result of individual and situational factor, workplace condition, and latent organizational factors and management decision. You might ask me, what could be the latent factor, organizational factor? It could be the structure. It could be the decision about the number of staffing for certain occupation, certain units, certain process. So all of this, it could be from the latent organizational factors. The more complex the organization, the greater potential for large number of system error. So when the organization expand, had more than one services, different population of their staff, diversity. I will give you an example from my institution, King Faisal Hospital. We have approximately currently 12,000 employees. And the number of nationality, it reaches about 75 nationality. We are coming from different countries, different schools, different practices, different community. So all of these are challenges that make our system more and more complex. Agree? Yes. Okay. All right, now talking about healthcare, what do you think? Where we are located in this graph? Are we in the dangerous zone where the opportunity for error more than 1 in 1,000, or regulated, or ultra safe where we have less opportunity for error? What do you think? Where we are? Where are we located as a healthcare setting? Regulated. Who can say regulated? Hands up. Okay. Who can say ultra safe? One. Why do you think we are ultra safe? Okay. Who will say dangerous? Two hands. Anyone? Yes. We are in the dangerous zone. Actually, these are real studies that shows and prove healthcare settings are located in the dangerous zone in this graph. All right. Unfortunately, airlines are in the ultra safe zone. Nuclear power, they are in ultra safe. Do you know why? Why nuclear power, they are located in the ultra safe? Yes? Excellent. They have a lot of measures, a lot of security check to make sure that the safety is maximized. So the process that could be done in 5 minutes, they do it in 15 minutes because of these measures. All right? So they are located in the ultra safe. This is a real statistics and study showing that really a healthcare setting. So student, medicine student, you are going to a real risk area. So you need to keep this in mind, and you need to do all the possible measures and be vigilant while you are working. 10% of hospital patients suffer adverse event, and the incidence of adverse event in developing country is higher than 10%. So again, this is statistic as per the WHO. So they define it as pandemic. It's a pandemic. And this is why there is a huge effort nowadays towards safety. And you can see nowadays the Saudi Patient Safety Saudi Center, they are having a lot of initiatives in the country and learning from other countries to help to minimize the adverse event. Preventable, of course, adverse event. I will not go in details in this slide. It has a lot of numbers due to the time limitation. However, this slide, it explains the statistics of, for example, those adverse events. Let's take one of those. Healthcare-associated infection. Let's talk about infection. They said hundreds of millions of patients are affected by infection worldwide each year, leading to significant mortality and financial losses for health system and patients. Medication error, one example. Leading cause of injury in developed or developing country, they said 1.5 million harmed and 1,000 killed in USA every year. And this is old statistic, 2006. So you can see unsafe surgery, clinical handover, injection safety, and so name it. Also, it has another side, which is the economic cost. If patient gets suffered from any adverse event, preventable adverse event, this means that he will expand the length of stay in the hospital. He will need more surgery, treatment. It could include surgery, intervention, and so on. So all of this, it will add cost. Now, quickly, just to look at what happened since this really been realized by our, I can say, community and internal and external. You can look at those milestones movement. Since 1990, James Rayson book, Human Error, was developed. He started to look at the errors. Then a Harvard study published in 1991, they start to unshed the light about this matter. Institute of Medicine, they report, it's very famous, Human to Err. They published their report in 1999. They were very transparent, uncovering all of these facts. The Leapfrog group being developed after that. Crossing the Quality Chasm report, it is similar to Human to Err in 2001. AHRQ, they've been developed later. After that, in 2002, National Patient Safety Goals, and after that, the International Patient Safety Goal in 2004. GCIA, Joint Commission Institute, they looked at what are the most risky area, and they consider it as a patient safety goal. Do you know, anyone heard about this International Patient Safety Goal? There are 6. Patient identification, high alert medication. Do you know what's high alert medication?
Medication that cause damage.
Why?
It has side effects.
Give me example.
For example, top of my head,
Warfarin, anticoagulant. What else? Insulin, narcotics, electrolyte, concentrated electrolyte, right? So all of these considered as a high alert medication. The possibility of serious consequences if any error happened with this medication is very high. This is why we call them high alert medication. It has its own list. So these patients also time out to make sure that the surgery is safe. Infection, healthcare associated infection, hand hygiene before you touch the patient, after you touch the patient, and so on. The last one is preventing fall and patient also identification. Especially in the Arabic country and Saudi Arabia, proper patient identification is crucial. Why? Who's Saudi? Similar names. Similar names. In my practice, I have about 30 years of practice. I'm a pharmacist in profession, so I was in a clinical field before I moved to quality. I remember I had many occasions, I can tell more than 10 occasions where 2 patients in front of me, let's say Noura Mohammed Al-Qahtani. The 3 names, not only the 2. The 3 names in front of me. So the common names are so frequent. This is why you need to be very vigilant and make sure to do a proper patient identification. And this is why they consider it in the International Patient Safety Goal list. Hippocrates, what he said, first, do no harm. This is first thing you learn in medicine that you need as a medical student and the future physician to do all of your efforts to avoid harming the patient. And when we talk about any adverse event, we talk about preventable adverse event. This is the famous International Institute of Medicine report that being published in 1999. It stated that between, again, this is a huge fact, and every patient safety lecture you will attend, you will find this stated there, that between 44,000 to 98,000 people die each year in USA hospital due to medical error. The cost, 29 billion annual cost. The majority of the problem are systematic. What does it mean systematic? That we can prevent it, we can fix it, and not the fault of individual of the healthcare provider. Why usually when any error we start to blame each other? No, it's the pharmacist's mistake, the physician. No, it's the nurse. Why we start to blame each other? It's the easiest way, right? So human nature and emotionally satisfying. We blame, we dump it on someone's shoulder. It's his mistake, it's her mistake. It sends a message to others that errors are unacceptable and needs punishment. So we are threatening each other. Don't do it. Okay? It is easier to attribute legal responsibility for an accident to the misconduct of those in direct control of the treatment than those at managerial level. صح? This is what happened usually, and we start to blame each other when error happened. So the big message, blaming individual equal lost opportunity to learn and ultimately protect the patient and ourselves. If I will punish you, you did a mistake, and I punish you, I fired you. Does this will prevent the error from happening again? It will come again and again. Why? Because it's embedded in our system, the processes that it didn't get fixed. Okay? So stop blaming. It's not, and report those errors and uncover it. Don't hide it. Have the courage to say, I did this, and try to fix the system. Look at the process in hand and see what gaps are in there and how you can prevent it from happening. Dig down and ask why and why and why. So when you look at the history, you find that before the Institute of Medicine report, the approach was person approach. While after that report, we start to look at what? System approach. So we start to stop blaming each other. We start to stop punishing staff. It doesn't mean that we will never punish. Of course, you need to evaluate. If there is a negligence, of course, it deserves disciplinary action. All right? So you need to evaluate. There is a special algorithm and decision trees that help management to decide the accountability of the involved person. So we are not saying that we are 100% free from punishment. So talking back about the person-centered approach and system approach, so we need to shift. We need to have a paradigm shift from this person approach to the system approach. What will happen? In person approach, individuals who make errors are careless, faulty, reckless. Directly blame and punish, then remove individual will help us to improve the safety. This is the beliefs. This is the perception. However, in the system approach, what we are going to look at, poor organizational design set people up to fail. Focus on the system rather than the individual, and change the system will help to improve safety. Do you agree?
Yes.
100%, yes. And later, inshallah, when you will become our doctors, you will be in the hospital, you will start to see this and understand this more and more. So why errors are occurring? Because we said complex healthcare settings are complex, right? Lack of adequate training sometimes, yes. Processes or system of care failure, and the culture of safety. There is a rule to identify the patient, but still I am deviating from the rule. So sometimes the safety culture among the employee is not adequate. So you need to work on the safety culture. 80% of errors or adverse events are system derived. Yes, this is proven that the most of the error happening and the preventable error, we are talking about preventable error, are stemmed from system issues. Now let's define those unsafe acts. We have violation and we have errors. When we talk about violation, from its name, we have system, we have processes, we have policies, we have pathways, protocols, but still you are violating this. What do you think we need here? To have punishment, disciplinary. It depends on the level of the harm. However, the error is failure to carry out a planned action as intended or application of an incorrect plan. While in violation, it's a deliberate deviation from an operating procedure, standard, or rules. Now, looking back to the error, action goes as intended, but it is wrong. Okay? And action does not go as intended. Of course, when the action goes as intended, but it is wrong, this is a mistake. It's unintentional. And an error is in decision-making or incorrect planning. While when action does not go as intended, it could be lapse, where it is an unobservable or mental error of execution, or slip, where an observable error of an execution. Okay, so let's have an example that will help us to understand this. Again, we agree, error, it is preventable we need to help, we need to coach, we need to fix the system, we need to train that staff and try to prevent that error from happening again. Violation depends on the level of harm the punishment will be. Let's have some example. You reach your car after a long work shift and you realize you left your car keys inside. Oops. What do you think this? Is it slip, lapse, mistake, violation? Yes, it's a lapse. Okay, why? Let's go back. Oops, how can I go like previous? Here بالkeyboard, yes, after. Okay, what we say, lapse, it is unobservable or mental error of execution. You didn't observe it. When you left that key in your car, you didn't realize that I did that mistake or that it's a lapse. While the slip, it is an observable error of execution. You were entering, for example, a medication for the patient on the previous patient page. You were treating a patient. When you finish, you didn't log out from that patient. The next patient came in and you slipped. Okay? So this is an observable error of execution. Do you agree? Okay. So let's have another example. By the time you get your key and finally get moving, you are so frustrated, you decide to take an illegal left-hand turn out of the parking lot to make up for the lost time. This is what? Mistake. This is a mistake. Okay? It's an intended. You did it. You observe it, but it's a mistake. You didn't do it for bad intention. You didn't violate the rules with a bad intention. You are frustrated. You get home and take out your keys to unlock the door. You put the wrong key in the lock and the door knob won't turn. This is what? Slip. Yes. Last one. Once inside, your roommate says, "Sorry, dinner is so cold. I thought you'd be home sooner. I made a..." It's a mistake. Okay? It's a mistake. Why? Why? Yes, he intended to do it because he assumed that he will come earlier. Okay? All right. Now, when you talk about patient safety, you need to consider concept or attitude with skills. So what are the things that we need to learn and to adapt and to apply? The new concept, the science of error causation, you need to understand it, how the error happened. Of course, usually there is many layers that could help in preventing those errors. For example, when you prescribe a medication, it will go in the system to who? To the pharmacist, who will review the order, make sure that the dose is correct, the indication is correct, blah, 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 blah. So the first layer, it's the pharmacist. Then it will go to the who? The nurse, who will administer. Again, she needs to look at the dose, at the medication, at the right time, and everything. So again, there is a many layer that help in preventing those errors from going on. So you need to understand when something happened, you need to understand how it's happening. Of course, if one of those layers didn't pay attention, not be vigilant enough to caught the mistake, of course the error will pass through and get to the patient and harm the patient. System thinking, again, always when something happen, don't focus on a human, focus on the system. Review the practice, look at those processes. Are you doing the best evidence, applying the best evidence? Maybe something that we get used to do it 10 years back, it's now an obsolete. We should adapt the new way. We need to understand that we are in a complex system. Just sending patient to OR, for example, it's really very complex. You need to decide on the type of the surgery. You need to get the consent. You need to prepare for the OR. You need to get the clearance from for example, from dental, from heart, and so anesthesia, and so on. So it's really very complex. Till you get your patient on the table and put knife to the skin, it is so complex. And many gaps could happen in between, leading to a serious outcome. Human factors, again, you need to consider this. How can I interact with that system as a human and make sure that I'm doing the correct thing all the time? Cognitive psychology and applied informatics. Sometimes informatics nowadays, it's really playing a great role in enhancing the safety. I will give you an example. Smart pump. Did you hear about a smart pump? It's a pump that it has a drug library inside it, and it is programmed in a way that it has soft limit and hard limit. The soft limit, it means that a drug level that you can override with your decision as a clinician and let the pump work with that dose. The hard limit, it means it's a red line. You cannot exceed or give below this dose. This is the hard limit. You cannot give over, you cannot give below. So it will alarm, it will not make that pump function because the dose is incorrect, okay? So this is how nowadays technology help in preventing errors. Barcoding and many. New attitudes, teamwork. I cannot function by myself. I need the nurse, I need the pharmacist, I need my technician. So the harmony that you have among the team help in having a safe outcome. Discipline, professionalism. It doesn't mean that you need to be my friend, my close friend, but I need to work with you in a professional way. No blame with accountability, of course, and disclosure. When error happen, we have nowadays a big policy about disclosure. When, how, who should do the disclosure to the patient or the family when an error happened. Skills, error analysis. There is huge information and knowledge about how you can do an error analysis and try to fix it. Leadership. Why we are saying leadership? The commitment of the leadership for safety is very crucial to help in the implementation and execution. I will give you from our example in King Faisal. There is a lot of initiative being applied in the hospital. However, it ends with zero or minimal outcome because the absence of leadership. When we get the leadership engaged with our daily practice, the things get improved. And this is what happened when we applied the high reliability concept in our hospital. And of course, a change management. Change management, it's a science by itself. You need to learn about, one of the pioneer is called his name, he's from Harvard School, his name, whatever, I will try to remember. He put like 8, Kotter, his name is Kotter. He's a professor in Harvard School, from business school. He put rules that we can apply. It's 8 concepts. First rule is creating sense of urgency. And this is what we are doing today with you. We are creating the sense of urgency to change, to apply the safe practice in your field. Key concept to advance patient safety: you need to recognize those errors, you need to investigate them, you need to engage the frontliner. Why we need to engage the frontliner? Because they are the most people knowing the secrets of the process, knowing how it can be applied in a better way. Now, being in quality management, Rania, when I get an error and we start to investigate it, I go to, for example, nursing professional, and I ask them, this has happened, and this is the process that's been utilized or applied. Tell me, you are the frontliner, you are the matter expert, and tell me how you can fix it. I cannot, as a quality professional, tell you how to fix it, okay? So frontliner engagement is very important, and everyone should consider safety priority number one. What are the current challenges in safety? The biggest challenge to moving forward for safer healthcare system is changing the culture. It's the culture itself. So what is the culture? It's the value of safety and quality are part of the very fabric of the organization. So it's the perception, it's the beliefs. How really we can look at the evidence related to relationship between organizational culture and patient safety culture. There is an empirical evidence that aspect of general organizational culture are strongly related to organizational climate itself of safety. So, and a higher level of a group culture correlated with higher level of safety climate. So this is need to be considered. Looking at the culture quickly, you need to know that it's a value equally the safety and healthcare of staff and patient. Safe and healthy staff ensure quality of patient care. So again, it's the staff themselves that we need really to consider always. It's not only the patient to be safe, also the staff. Commitment to the safety culture and open communication. We will talk about communication. Now, looking at the level of the safety culture, we have different level of safety. We have the pathological, where is the status quo, no effort, nothing happening. We have the reactive, we have bureaucratic, we have proactive, and we have generative. So there's a definition for each one of those. I will not go in details. However, when you work in an institution, you need to evaluate. There is a certain assessment can be done to look where you are as an institution and look how you can improve and how you can go up the pyramids to be in a generative level that all the organization, healthcare organization must be in. Okay. How can you contribute to safety culture? Positive tone, set common goals, communication. It's a key. And system error and unsafe behaviors. Fairness algorithm, when something happen, you don't punish directly. There is certain algorithm that you can apply to determine the level of disciplinary action. And of course, being respectful and approachable. Now, I know that we are running out of time, so I will try to look at, of course, for the safety culture, we have an annual survey that we do at national level that help us to assess and look where we are on annual basis. And it's one of the Sibahi. Sibahi, of course, it's an organization that it's a mandatory accreditation system at national level, and they mandate the safety culture measurement in the organization within the country. Now, talking about home. Now, safety at home, of course, when you treat a patient, there is a transition from the organization to the home. You need to look at different aspects that there is many studies, they focus on medication at home, care at home, environment of that home, how to prevent falls, especially for elderly. So it doesn't mean when you discharge the patient that your job is done. No, you need to look at how you can make sure that this patient will really be safe also at their home, and it's the responsibility of that organization or that physician. So communication, we talk about the importance of communication. where to talk. Again, it's a complex. Nurses to nurses, physician to nurse, name it. As you can see, it's so complicated. You need to improve the communication at two levels, improving the mechanism of the communication and improving the message being communicated. So two things. Now, in King Faisal, we applied, as I said, the high reliability concept. And we looked at what is high reliability. It's the organization that are high risk, dynamic, turbulent, and potentially there is a potential for errors. However, they have minimal errors. And they have different concepts that they are applying to make sure what? They are exponentially safe and constantly applying high quality of care. These are the concepts: preoccupied with failure, sensitivity to operation, difference to expertise, the frontliner, they are the experienced people, resilience, when error happen, you go back, learn and continue, reluctance to simplify, and so on. These are the concepts that they should apply. These communication skills, we look at ISPAR, maybe you heard about it, where it's a tool that you are applying to make sure that you are consistent in delivering your message. Introduce yourself, talk about the situation, background of the what's happening, my patient having this and this and that. You do your assessment, so you explain what you have done, then you recommend what you want. This is an exercise on ISPAR that we will quit. Talking about how you convey message, 3-way repeat back and 3-way read back. First of all, sender initiate the message, receiver acknowledge, and the sender acknowledge the accuracy of that information. When you have a critical findings, for example, you need to make sure that the receiver will put it down and he will read back. For example, high potassium, any critical, certain level, hemoglobin dropping down or so on. So you need to write it down and read from that to make sure that you listened and you understand what the message is. Clarifying question, phenotypic clarification, number clarification, all of this, it helped to augment the communication way among the healthcare setting. This is a video, I'm sorry that we will not display it, talking about handover. Handover, it's again, it should be structured. You need to have a systematic way of doing that handover. It could be between same profession, or it could be from, for example, physician to nurse, physician to pharmacist, and so on. Okay. I think I talked about most of the concepts. Sorry to stay long. I can talk for the end of the day. Thank you for listening. I hope that you get the message, and we'll see you, inshallah, next occasion. Thank you.